students, let's study the module on hair and its disorder. In this module, first we will study the anatomy, followed by the hair cycle and correlate the related disorders. There are three types of hair in the human body: lanugo, vellus and terminal. Lanugo is present in the prenatal phase. It is not present after birth. So here we said it is present in the prenatal phase. It is shed off during the intrauterine life. The diameter is 40 micrometer and does not have a medulla. Vellus hair, the diameter is less than 30 micrometer. Vellus hair are thin, fine hair which are present in certain parts of the body. The anagen hair bulb is present in the reticular dermis. Medulla is absent here also. Now, where all is vellus hair present on our body? So, wherever terminal hair is present, except for that, our entire body is covered with thin, fine vellus hair. So, axilla, beard and trunk are the regions where terminal hair is present. The terminal hair is androgen dependent and the vellus hair in these particular regions get converted into terminal hair during puberty. The terminal hair is a thick, black, dark hair which is diameter is 60 or rather 70 micrometer. The depth of the anagen hair bulb here is in the subcutaneous tissue. They are also present on scalp, eyebrow and eyelashes. So just for clinical correlation, this was the epidermis. The upper part was the papillary dermis. The lower part of the dermis is reticular dermis. So epidermis, dermis. And the bottommost part, subcutaneous tissue. So reticular dermis is somewhere here where the follicle of the vellus hair will be present, and subcutaneous tissue is somewhere here where the anagen bulb of the terminal hair will be present. So what are the clinical implications of knowing different type of hair? In a condition called as hirsutism, seen in females, the areas where vellus hair is supposed to be present, like commonly chin, gets converted to terminal hair. So vellus to terminal hair. And in androgenetic alopecia, opposite happens. The terminal hair gets converted into vellus hair. So remember these two. Moving on to the next. The image A shows lanugo hair, B shows vellus, C is an intermediate, D is terminal. We can see the hair bulb is located deeper. E shows sebaceous hair follicle associated with a sebaceous gland. But all of these hair follicles are associated with the sebaceous gland. Let's look into the structure of the hair follicle. So here is the skin. The hair follicle extends deep down to the subcutaneous fat. So anatomy, why is it important to know? Because the entire hair follicle that we see here is not permanent. The upper part of the hair follicle, which is the infundibulum and the isthmus, is permanent. And the lower part, which is the suprabulbar and the bulb, are cycling. So during every hair cycle, the upper part here remains constant, the lower part here remains cycling. So the infundibulum is the entry point or the funnel shaped entry of the hair follicle. It starts from the surface of the skin and ends at the opening of the sebaceous gland, as we can see in the picture. After infundibulum, the isthmus starts, where the infundibulum ends. After that, the isthmus starts and extends to the insertion of the erector pili muscle. Alright, the muscle that we see here is the erector pili. So this is isthmus. The bottommost part is the bulb, and above the bulb and between the isthmus is the suprabulbar region. So what is the function of this erector pili muscle? When it contracts, it causes piloerection. That is when we see goosebumps during shivering. It is a function of the erector pili muscle. When this bulb and the bulge portion, so the bottommost part is the bulb, there is a bulge here in the middle of the hair follicle. These two regions contain stem cells. Any disorder, inflammatory disorder, if these stem cells are destroyed, the hair follicle, the lower cycling part, cannot regenerate, and because of the destruction of stem cells, scarring alopecia is seen. So these stem cells, where all they are present here, they are present in the bulb region, they are present in the bulge region also, and a little bit of them are present in the sebaceous gland as well. Moving on to the layer of a hair. So this is the hair. This structure here, the outside region is the follicle. So we are going to be studying the layers of the hair. From inside to outside, there is this empty cavity which is called as the medulla, which we studied was absent in the vellus and lanugo hair. Followed by the medulla comes the cortex, and after the cortex comes the cuticle. So these three are the layers of the hair shaft, which is here. Now this hair shaft is covered in other multiple layers. The inner one is inner root sheath. The outer one is known as outer root sheath. Between the inner and the outer root sheath are the Huxley and the Henle layer, followed by the glassy membrane here, and this entire hair follicle is surrounded by the connective tissue, which keeps the hair follicle in place and anchored. Phases of hair cycle. So our hair is not constant in one phase. Anagen being the growth phase, catagen is the involution phase, telogen is the resting phase, exogen when the hair is pushed out of the follicle. So imagine this, if all our scalp hair are in the growing phase together, it's nice, it's growing, we have thick long hair. But if all 100% of our scalp hair go into the involution, that is the process when the hair fall begins together, then suddenly we will not have any hair on our scalp. Hence, the cycle is divided partially. While somewhere new hair is growing, in other parts the old hair is falling off. Hence, the phases run parallel to each other. And at a given point of time, this hair on our scalp can be present in each of these phases. Let's look at the difference here. So these were the names. Now 80 to 90% of our hair is present in the anagen phase. And anagen phase is the longest on scalp and approximately 3 years. So the length of the anagen phase in time corresponds to the length of the hair. Approximately 1% hair is in the involution phase, and the duration of catagen is 3 weeks. And the remaining 20% is in the telogen phase, and the duration is 3 months. So in the resting phase, the follicle is resting in the telogen phase, accumulating all the nutrients that it requires to grow in the anagen phase. And once the telogen phase is completed, the old hair is lying on the side and the new hair has already started growing in the anagen phase, The new hair comes up, pushes out the old hair, and the hair falls. This is the exogen phase. What are the function here? Thermoregulation is prevent heat radiation. Physical barrier is protective against UV. And vernix caseosa acts as a lubricant in the intrauterine life. Regeneration and repair because the stem cells are present in the bulge and the bulb region. Secondary sexual character is the conversion of vellus hair to terminal hair during pubertal phase. Acts as touch and vibration receptors as well to a certain extent. Of course, social interaction and medico-legal value for DNA analysis, heavy metal poisoning, and any toxin analysis. What are the disorders? So, when the hair is lost, there can be two types of disorders, non-scarring and scarring, as the name suggests. If a scar is formed, it's a scarring disorder. An increase in hair growth is hirsutism and hypertrichosis. Scarring disorders are also known as cicatricial hair loss. So what is the difference between scarring and non-scarring? The hair follicle is lost in scarring. Inflammation is present in scarring disorder. Atrophy is present and hair growth is absent. So everything opposite here will be non-scarring disorder. Hirsutism is the conversion of vellus hair to terminal hair in a woman. Alright, and where? In a male distributed pattern. Like beard is supposed to be in male, not in female, so in a male distribution. Hypertrichosis, increase in lanugo, vellus or terminal. So focus here, hirsutism has excess of terminal hair, hypertrichosis has excess of all of these three. Under the heading of non-scarring disorders, we will look at all of these. Non-scarring also includes two main infections. Non-inflammatory tinea like grey dot and black patch. And the secondary stage of syphilis, the alopecia, is classically known as moth-eaten alopecia. Let's start with alopecia areata. Alopecia areata is an autoimmune disease. Why does alopecia areata occur? So normally our hair follicle is an immune privileged site, meaning the MHC molecules are underexpressed here. MHC molecule play an important role in attracting the inflammatory cells and causing destruction. Since in the lower cycling part, the MHC molecule are down-regulated, our inflammatory cells do not target this region. So hence immune privilege. But for certain reasons, autoimmunity develops against this. They target the lower portion of hair follicle leading to hair loss. Hence a disorder known as alopecia areata. So clinical feature will be as we can see here, they are well defined patches of hair loss, non-scarring type. Nails will show pitting, which will be fine and regular. In psoriasis, we will study the pitting is coarse and irregular. One more interesting clinical feature in alopecia areata is The disorder preferentially prefers black hair. If there is a sudden onset, overnight all the black hair will fall off and white will remain. This is known as Marie Antoinette sign. Another classical feature is at the border where the activity is there, we find exclamation hair. As the name suggests, the shape of the hair is like an exclamation mark. A normal shape of the hair is inverted. So, exclamation hair. Remember these two? Non-scarring type and fine regular pits. So what are the prognostic factors? The bad prognostic factors are when it starts early in the age, so early onset, associated with atopy, thyroid disorder, family history. The hair loss occurs in certain patterns and some of the patterns also have very bad prognosis. The patterns are, one is localized, which is shown in this picture, random but localized patches. They do not involve the entire scalp. The second one is ophiasis, which is in the occipital region, just behind, from one ear to the other ear, behind in the occipital region. Alopecia totalis, total scalp is gone. Universalis, hair over the entire body is gone, mainly the scalp, the eyebrow, mustache and the beard area. So, ophiacis, totalis and universalis are the bad prognostic factor. There is one more which is the reverse of ophiacis, known as Sisypho. Ophiacis was in the occipital region, Sisypho will be in the frontal region, a band of hair loss. The commonest association will be thyroid followed by vitiligo. So what is a histopathology? The classic histopathology is, look for this word here, swarm of bee appearance. What is swarm of bee appearance? Is the hair follicle has a lot of lymphocytes surrounding. So lymphocytes surrounding the hair follicle gives a swarm of bee appearance here. Peribulbar lymphocytes and an anagen hair bulb. What is the treatment? The drug of choice for localized alopecia areata is steroid, but what kind? Intralesional steroid. In widespread disorder, the drug of choice is cyclosporin. Oral corticosteroids, azathioprine, can also be given. There is a different type of therapy called as sensitization therapy, where what happens is a irritant chemical will be applied on the skin. This swarm of bees leave the follicle alone and get attracted here. So the hair follicle is not damaged. This is known as sensitization therapy. The agent used here is DPCP. And the regimen followed is Happel's regimen. Newer drugs used for treatment of alopecia areata are JAK inhibitors, which are tofacitinib, ruxolitinib, and the newest out of this is baricitinib, which is FDA approved for treating alopecia areata. The next disorder here is trichotillomania. It is an obsessive compulsive disorder. How is it different? It is non-scarring, but the patient will keep pulling their hair out. Clues here is when there is hair is pulled by force, not necessary it will break at the same length. There will be incomplete hair loss. The patient can't pull out hair uniformly, every single one, leaving a well-defined patch. Perifollicular hemorrhage because of the trauma. And if I'm right-handed, I would prefer the right hand for it. So dominant side is a clue for it. There are other psychiatric disorders related to hair. The first one is trichorhizophagia, which is patient eat the hair root. Trichophagia, where whole hair is eaten. Trichobezoas, because of eating of this hair, there is a hairball in the GIT. So there is thinning of hair. You can see variable length, alright. Next is infections. Tinea and syphilis are the two infections that cause non-scarring hair loss. We will study about tinea in great detail under the chapter of fungal infection. Two types of non-scarring hair loss caused by tinea being grey patch and black dot. Syphilis, secondary syphilis, causes moth-eaten alopecia. One more inflammatory disorder is SLE, which also causes non-scarring hair loss. The next is telogen effluvium. This is diffuse loss of hair seen when the body undergoes any stress. If the body undergoes any stress, all the nutrients are diverted to other parts of the body which need them to repair. Physical stress, if the patient is sick, mental stress, any kind of stress. So pregnancy, surgery, anemia, infection, all of these can be a type of stress. It leads to premature termination of anagen phase. So the key word here is premature termination of anagen phase. And after 3 months, the hair loss is seen. Anagen phase does not get enough nutrition and the hair falls off. We will discuss the treatment in the subsequent slides. Anagen effluvium is the hair loss in the anagen phase. Telogen was hair loss in the telogen phase. In telogen effluvium, the anagen hair quickly enters the telogen phase and stays in it for a long time. In anagen phase, the hair starts falling from the anagen phase itself. Important triggers are chemotherapy and radiation therapy. Starts 3 to 4 weeks after the chemo or the radiation therapy. What is androgenetic alopecia? Alopecia dependent on androgens. So this is hormonal alopecia, commonly seen in male, known as male pattern hair loss. In females, known as female pattern hair loss. We did not use the word patterned hair loss anywhere because hair was falling in any diffuse pattern. Here it is falling in a specific pattern and there is a difference that we will see. Anagen phase is shortened and the hair follicle size is reduced. Why does it happen? One, it is genetically predisposed. Second is because of hormones. The androgen receptors present on the hair convert the testosterone to DHT by the presence of enzyme 5-alpha reductase. This DHT binds to the androgen receptor on the scalp and provides a trigger for hair loss. One interesting thing is it spares the occipital region. So naturally this DHT is the culprit here for causing the hair loss. So just think, how will we treat it? We will prevent the formation of DHT by giving inhibitors of this enzyme that will stop the DHT, namely finasteride and dutasteride. Can be seen in men and women both, and occipital sparing is a classical feature. Norwood-Hamilton grading is used for men. It starts from the biparietal region, then frontal, the vertex involved, but what we can see is occipital sparing. In females, Ludwig scale is used, and the pattern here is the central hairline gradually widens on both sides. Here, it was recessing behind the hairline, can we see? Central hairline is not widening in any way. So, clue to widening of central hairline is FPHL. How do we treat it? AGA is treated with minoxidil, which comes in a solution form in 2.5, 5, 10 and 12.5. It is a vasodilator. Initially, it was used for treating hypertension, and suddenly the people who were treated, hair was seen. So this is known as serendipity in dermatology. One drug was used for a cause, but a second effect was seen. Finasteride and minoxidil are also used as topical therapy. So if it is a vasodilator, the side effect is hypotension and headache. So always take a history of blood pressure in patients to whom you will prescribe. Oral minoxidil and finasteride also are available. Oral minoxidil in the dosages of 2.5 milligram and finasteride here is used as 1 milligram. The FDA approved dose of finasteride, which is a 5-alpha reductase, 5 milligram is for benign prostatic hyperplasia. Remember that 1 mg is used for hair loss. The other 5-alpha reductase, the newer one, is dutasteride. Platelet-rich plasma, low-level laser therapy and hair transplantation also can be used. PRP and low-level laser therapy is used for telogen effluvium also. Here in telogen effluvium, always treat the underlying disorder. Scarring alopecia, where there is hair follicle inflammation, the hair follicle dies, the hair never comes back. Primary, because there is no external underlying cause. Secondary, there are underlying causes like infection, trauma, sclerosing disorders like scleroderma, where hair follicle is destroyed, all appendages are destroyed. Granulomatous are due to intense inflammation. Primary is due to autoimmune disorders. The immune privilege that we had discussed about is lost here. So DLE is one common one of cause of scarring alopecia. DLE is a type of cutaneous LE. It causes follicular plugging. The lesion is a plaque where there is central atrophy, heals with a zone of pigmentation and the surrounding active zone has erythema. So central atrophy or pigmentation is characteristic. So the hair follicle is here. The plaque that is formed plugs the hair follicle like this. So when we peel this plaque off, you can see whatever had plugged the hair follicle. So this is known as a carpet tack sign. This is due to lymphocyte infiltration. The treatment here will be high potent topical corticosteroids, or if localized, it will be intralesional steroids. Lichen planopilaris is the lichen planus of hair. Itching, burning, irritation are the symptoms, but anything lichen planus has to be purple or violet. So violaceous papules will erupt first, which ultimately lead to scarring. The end stage of LPP is known as pseudo pelade of Brock, which has a classical appearance known as footprint in snow. Drug of choice again will be corticosteroids. So to summarize it, to find out whether the disorder is scarring or non-scarring, look for the presence of or absence of hair follicle. If it is non-scarring, it can be reversible. This will be irreversible. Scarring alopecia, if in the growing stage or the developing stage, the disease process is still active, can be controlled by giving corticosteroid. Let's look at the MCQs here. 35-year-old male, alright, crown and frontal. So progressive thinning is there. Father also had the history, it means genetic predisposition. On examination, M-shaped hairline. So let's just go back to the photo here. What do they mean by M-shape? This is what they mean by M-shaped hairline here, okay? What is the most likely treatment? So because of the clues mentioned here, androgenetic alopecia, male pattern is shown. So the treatment will be, first let's look at it, androgenetic alopecia and topical minoxidil. 25-year-old female presents with diffuse hair loss for the past 3 months. There is no pattern here, it's diffuse. Following fever, that means following an episode of stress. Hair pull test is positive. Hair pull test meaning when you hold a hair between your thumb and the index paper and pull it out, you see approximately 10% of the hair falling. So what is it? This is indicative of telogen effluvium. Cicatricial meaning there will be scarring, there will be a proper pattern of hair loss, it won't be diffuse. Alopecia will also be a well-defined patch. Trichorexis nodosa is nodular appearance along the hair shaft. 28-year-old man presents with patchy areas of hair loss on his scalp and beard. Smooth skin, no visible scarring. Swarm of bee appearance. So first it is a non-scarring alopecia. It is a patchy non-scarring alopecia. So, and swarm of bees. It is areata. What is the most appropriate treatment? Intralesional steroid. Minoxidil plays no role. Finasteride also plays no role in alopecia areata. Both of them are used for androgenetic alopecia. Single patch of alopecia areata, always it is a intralesional corticosteroid is the choice. Methotrexate can be used in universalis or totalis. Based on the image, hair loss with central pigmentation, scarring and peripheral hyperpigmentation. What is the associated management? Classical description of DLE. Therefore, the drug of choice would be hydroxychloroquine, which is an anti-malarial. Here, why is topical corticosteroid not a choice? Because the area has already scarred, okay? There is no active inflammation. If there was active inflammation, we could have preferred topical corticosteroids. But since it is already scarred and asked for an associated management strategy, the answer here is hydroxychloroquine. Which of the following mutation is most commonly associated with development of androgenetic alopecia? Mutation in androgen receptor gene. So which of the condition is characterized by presence of hair follicle unable to produce normal hair due to defect in keratin shaft? So we have not covered this part in this module. And in the exam, if such a question arises, try to rule out what you know instead of knowing the right answer directly. We know alopecia areata is due to lymphocytes attacking the hair follicle. Trichotillomania is an OCD. I don't know what monolithics is. Telogen effluvium was due to presence of a stressful condition. That leaves me with monolithics, which is the correct answer. What is it? It is a disorder of the shaft, not follicle, due to increased fragility. It is a congenital disorder. Increased fragility due to defect in keratin formation here. Hence, that is called as monolithics. Other congenital disorders of hair shaft are pili torti and trichorexis nodosa. Here we come to an end of this module. Thank you so much.